The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. Thank you so much for spending your lunch hour with us today and joining us for this Lunch and Learn with Evoke Neuroscience. Before we begin, let me introduce myself. My name is Morgan Edmondson. I'm the Medical Affairs Manager here at Evoke. I'm going to be walking us through today's Lunch and Learn presentation on recognizing traumatic brain injury. If you've joined us for these sessions before, you'll know that they give us a chance to look at some of the biomarkers that the research tells us are related to different patient types. We've done a session on memory loss and depression in the past, and today we're talking about TBI. So to get started, let's review our learning objectives for today. We'd like to strengthen your understanding of functional physiology metrics and learn how to recognize key biomarkers of TBI. So at the end of this section, we want you to be able to define heart rate variability, and that includes the time and frequency domains, describe changes in HRV associated with traumatic brain injury, define event-related potentials, that's our brain processing speed, and describe changes in ERP speed and power associated with TBI. We want you to interpret database comparison EEG head maps and recognize changes related to TBI. And finally, we want you to be able to offer individualized neurofeedback options to your patients. So really today we are going to review our electrophysiology metrics, have a strong foundation of what the metrics are. We'll talk about clinical research of why those metrics are important to consider for patients with TBI and teach you how to recognize those biomarkers in a report format. So first, starting off with a bit of background on TBI. It's a really big problem. It's very common. 3.8 million people every year in the United States experience a concussion. And symptoms vary a lot. It can affect mood and affect, attention, arousal, language, memory. And a key problem in diagnosing TBI is that the current standard tests don't directly measure brain function. That's a problem because it's a brain injury, so really we need to be looking directly at the brain, taking a look under the hood at brain function in order to understand how the brain was affected, how it's healing, if the person is ready to go back to play. So the problem with these standard tests is that they're very susceptible to patient motivation, honesty, or best effort. If it's not purely objective and has a subjective component, perhaps the patient is skewing their results at a baseline test, they're purposely trying to perform poorly, perhaps they're just not motivated, they're not trying very hard. So all of these confounds really pose a lot of issues to our standardized tests that we use now. And even when we attempt to use really objective measures like structural neuroimaging, oftentimes those still fail to identify injuries because TBI is really a functional injury. It relates to how the brain is functioning, and it doesn't necessarily present with a structural lesion. So it's really important to consider brain function, not just neuroimaging the structure. Now, when we think about TBI, first that probably comes to mind is concussion, sports-related injury. This is what the NIH calls blows to the head, as usually in sports-related injuries. And the question here isn't usually, was there TBI or was there a head impact during a football game, during a soccer game? The question the athlete wants to know is, when can I return to play? When has my injury resolved? When am I healthy enough to get back to my sport? Now, we also can see patients in our practice that have experienced falls or motor vehicle accidents, and the question then might be a bit more of a mystery. The question isn't, oh, I've had a head injury and when will I get better? The question could be, what's causing my symptoms in the first place? So we're kind of dealing with two different aspects of the problem here. One for athletes, when can I return to play? And one for patients, what's wrong in the first place? Could a TBI be behind your symptoms? So let's start out with a case study, just an example of kind of what the world looks like without using these electrophysiology metrics. So we have a 65-year-old male that comes into the office with word finding difficulty, trouble focusing, and drastic mood swings. So we perform a neuropsychological screener. They're self-reporting their symptoms, kind of describing what they feel is wrong. And sure enough, they have concerns with the attention, word fluency, and affect. So our initial one-on-one interview with them was pretty accurate. They're being honest in the symptoms they're reporting. And if we assess them behaviorally, we do see some evidence of a problem. They have pretty delayed motor speed and reaction time. So we know that they are having symptoms, but we have trouble identifying what the cause of these symptoms are. It could be stress and anxiety, it could be depression, it could even be a TBI. Now, this patient hasn't directly reported, oh, I had a huge car accident 2 weeks ago. But if there's biological signs of a brain injury, when we look at the way the brain functions and the electrophysiology biomarkers we'll talk about today, it can give us insight and have us ask more questions about what could have possibly happened in the past that could be causing these symptoms. So maybe it is a brain injury after all that is causing the patient to experience these type of symptoms. But the current approach doesn't give us those objective biomarkers, right? Our standard testing only detects symptom resolution, but not injury resolution. So we would be able to detect, yep, your symptoms are gone. It seems like you're good to go, but that might not be the case because symptoms often resolve prior to the brain injury resolving. And this really gives us a false indicator of recovery. Now, as an example, let's kind of walk through the stages of recovery after a concussion. And we have our baseline health, we have an injury, we drop down to a lower level of functioning when we have our symptomatic phase. We kind of do this rest and wait approach. All of a sudden we have spontaneous symptom resolution. We no longer are experiencing symptoms. We think we're great and back to normal. And in the case of an athlete, oftentimes once they're asymptomatic, they return to play. But really what's happening is injury resolution takes much longer in many cases than symptom resolution. So during this period of asymptomatic, but injury is still occurring, we have this false recovery. And this is kind of the danger zone. We don't want an athlete to return to play when they are still experiencing an injury, but they don't have symptoms. We want them to get to true recovery. Their brain has healed, they're feeling good, and now they're ready to play. So the question is, how do we detect this point? We know how to detect this point when our symptoms have resolved. That's relatively easy to do. The challenge is, how do we detect when the brain injury has resolved and now they've reached true recovery? Additionally, we kind of have a problem that injury resolution can take a really long time in many cases. And is there any way we could speed up this injury resolution curve so our asymptomatic but false recovery phase is shorter and we get to true recovery faster? So the current treatment just uses a sit and wait prescription. It doesn't directly rehabilitate the injury itself, but we can use approaches like neurofeedback to directly treat that functional injury. And we'll talk about neurofeedback as we get to the end of today's presentation. So as I mentioned at the beginning of the presentation, objective electrophysiology can be very helpful when we are treating patients with traumatic brain injury. We know that functional neuroimaging via EEG is well established, non-invasive, affordable, and it's office-based. So you're keeping your patients in office, you're trying to get to the root of what's going on directly in your office without having to refer them out to really expensive neuroimaging techniques. And oftentimes those techniques are structural. So in the case of a TBI, when we have a functional injury, things like an MRI might not even be that valuable. So these objective measurements don't rely on self-reports, which is critical when we're talking about athletes that are just so eager to get back to play. And there are a lot of research-backed electrophysiology metrics correlating to TBI. This is a very well-researched part of electrophysiology, how it relates to head injury. And we're going to be talking today about EEG, ERPs, HRV, If you want to do a quick Google search on your own, you'll find plenty of research to do further reading. And we also know that biofeedback can be used to target and correct brain imbalance correlated to behavioral symptoms of TBI. So electrophysiology not only is giving us the opportunity to detect biomarkers of potential TBIs, but it also gives us the chance to facilitate rehabilitation to injuries the brain has experienced. All right, so a quick review of the key biomarkers correlated with TBI we'll be talking about today. First up is ECG heart rate variability. We're going to be keeping an eye out for reduced heart rate variability. Now, if you're not familiar with HRV, worry not. We're going to go into detail on it, explaining what the metrics are, why we care about it for our patients with possible TBI. We're also going to talk about event-related potentials, our brain processing speed, and specifically the P300 component of ERPs. And finally, we'll talk about resting state EEG. We'll cover how to interpret head maps, and we'll cover what to look out for in cases of TBI, which includes high or low power in slow frequencies and or focal neuroinflammation. Now, if what I just said is confusing, we're going to decode it and walk through it together. All right, so starting out first with heart rate variability, this is derived from ECG or EKG, and the reason why we're looking at the heart for a brain assessment is because there's synchronized electrical activity between the brain and other body systems that underlies our ability to perceive, feel, focus, all of those things, and ultimately perform at our best. So this is an example of why we're looking at something like heart rate, which affects cardiac output and blood pressure, which gives us insight then into the autonomic nervous system, which is responsible for our sympathetic activation, fight or flight mode, and parasympathetic activation, rest and digest mode. But heart rate alone isn't going to give us this kind of insight. What we really want to look at is heart rate variability. Now, that's a measure of neurocardiac function that reflects this heart-brain interaction and therefore autonomic nervous system dynamics. So heart rate variability really has two components. The first is a time component. That makes sense. We're looking at variability in heart beat-to-beat intervals, so that's related to time. And the second is a frequency domain, which I'll decode in a moment. But first up, time. Again, how much variability is there in heart beat-to-beat intervals? So now many patients have the misconception that the heart beats like a metronome, but actually the heart beats erratically, and that's a good thing. A healthy nervous system responds in real time to what the body needs, so an ideal heart rate variability is actually high. There's a lot of variability between each beat-to-beat interval. So one time domain metric of HRV is called SCNN. That stands for the standard deviation of end-to-end intervals in milliseconds. Basically, it looks like this in a graph form. We're looking at end-to-end intervals, measuring the amount of time between those intervals. We see there's a long one, then a short one, then a long one. And that's good. That means there's high heart rate variability. That would be a high SDNN. And a high SDNN is correlated with lots of good things like overall heart health, low stress levels, and good autonomic resilience. So that's our time domain for HRV. Now let's talk about the frequency domain for HRV. And this basically asks what the underlying rhythms are in this heart beat-to-beat intervals. So just like the brain, the heart beats in rhythms, and these rhythms can be graphed according to frequency. So let's first draw our attention to this top graph. On the x-axis, we have time, and on the y-axis, we have heart rate. So this top graph that says original waveform for our HRV is actually the instantaneous heart rate that somebody has over time. So our heart rate, we're measuring at instantaneously that beat-to-beat heart rate, and it's fluctuating throughout time. Now, if we use a computer algorithm to filter this out, we can detect slow waves, medium waves, and fast waves. These are called very low frequency VLF, low frequency LF, and high frequency HF. Now, the reason why we care about filtering out this original waveform into these slow, medium, and fast waves is because each of these rhythms is related to a physiologic process. So these slow waves, VLF, are related to sympathetic arousal. Medium waves, LF, are related to balanced autonomic arousal, and high frequency waves are parasympathetic arousal. So now the question is, how much of these waves do we have? So that is phrased a different way. How much power does each underlying rhythm have? Power is just like measuring how much is present. And in this graph, let's look at the x-axis, which is our frequency. We have our VLF, LF, and HF, so our slow all the way to fast waves. And remember, we know they correlate to sympathetic, balanced, and parasympathetic activity. Now, on the y-axis, we have power. That's just asking how much is there. So ideally, we would like to see a distribution where the most power is in this balanced region. That means we can easily shift from sympathetic to parasympathetic activation, and we're balanced between the two. But what this graph is showing now for this patient, somebody has too much sympathetic activity, and they also has too much parasympathetic activity. So this person's very tired, and they're tired of being tired. Now, we can also consider what is called total power, and that's the combined power across all of these frequency bands. Generally, we'd like to see the higher the total power, the better. And that kind of goes hand in hand with our time domain, SCNN. So the higher SCNN, the more variability, the better. The higher total power, the better. All right, so why do we care about HRV when we're talking about traumatic brain injury? This is a snapshot of HRV for a healthy control and for an athlete that is 2 weeks post-concussion. Now, first of all, you might be questioning what this graph is and what does a HRV waveform look like in a graphical setting. So let me kind of break this down, what it's showing, using first a cardiac waveform. So this normal PQRS waveform we're familiar with. And what we're doing here is taking these end-to-end intervals and how far apart they are, and then graphing them according to time. So this heart rate variability is looking at the variability in these end-to-end intervals over time. All right, so now let's look at some differences between our healthy control and our post-concussion athlete. The first thing that I'm noticing is that there's poor rhythmicity for our athlete. They don't have this wave that goes up and down very regularly, which shows that there's a high heart rate variability. Instead, our athlete doesn't really have any consistent rhythm. It's very jagged. Now, poor rhythmicity here is relating to reduced heart rate variability, and really what will show up as reduced SCNN, which remember is our time domain metric for HRV. So in a study that was looking at mild traumatic brain injury patients after their injury, they measured that the time domain for heart rate variability was reduced in our concussed patients compared to control patients. So we're going to keep out for a reduced SCNN in patients with possible TBI. Now, the other thing I noticed between this healthy control sample and our post-concussion sample is that there's very low amplitude on this post-concussion graph. Now, that relates to overall low total power. Remember, total power, we want to be high. That's indicative of good heart health, good autonomic resilience. But here we're seeing that this patient has low total power. Now, in this same study of looking at TBI patients, they found not only is low total power a good indicator and biomarker of TBI, but also TBI patients tend to have sympathetic dominance. So here on the y-axis, we're looking at the sympathetic to parasympathetic power ratio. So higher numbers here means there's more sympathetic activity than there is parasympathetic activity. We look at our concussed patients and we see that they have more sympathetic activity compared to their parasympathetic than controls do. So when we look at our biomarkers, we're going to keep out for reduced time domain, reduced HRV, and we're going to keep an eye out for possible sympathetic dominance. All right, so HRV and the report, things to keep an eye out for when we're assessing different patients. Patients with TBI might show reduced SCNN. We talked about the time domain being affected, so heart rate variability is a low result here compared to our reference range. Remember, ideally, we'd like to see a high SCNN, and a low SCNN could be indicative of somebody with TBI. It means that their sympathetic autonomic nervous system is in sympathetic overdrive. Additionally, we might see reduced HRV total power, and we might see sympathetic dominance, meaning our very low frequency is too high. Now, in a graphical representation, this is what it would look like. Our red band, our sympathetic band, has too much power. Our balance and parasympathetic bands don't have enough power. Okay, so HRV is done. Now we're all experts in HRV. We know what to look for patients with possible TBI. Let's move on to our event-related potentials, our brain processing speed. So ERPs are an EEG-derived metric, and they reflect brain processing speed. And we do this by looking at a time-locked neural activity, which relates to sensory and cognitive processes. So this graph is on the x-axis time, latency in milliseconds, and on the y-axis is voltage. And starting here at the intercept is our stimulus onset. So during an EEG, we give somebody a stimulus to look at, and we look at the way their brain processes that information, and we get this event-related potential waveform. Now, there are different components to this waveform, which are denoted here, P123 and 12. And this naming convention is pretty simple to follow. The P or N stands for positive or negative voltage. So we care where it's going on the y-axis. Is it going positive or is it going negative? Now the number is related to latency time. Here, P3 stands for P300 because this component of the waveform usually occurs around 300 milliseconds after the person sees the stimulus. So we care about our power, our positive or negative, and we care about the latency. So when we're talking about event-related potentials and how our patients are doing, there's two components: speed, which reflects how long the brain is taking to mentally classify a stimulus, and power, which reflects how many neurons are successfully working together to process this stimulus. Now, if you can remember why this naming convention exists, then you'll remember that you care about speed and power. P means positive, so I care about the voltage and the power. And 3 means 300, so I care about the speed and the latency. So when we interpret ERPs, we can this is just a graph that shows our control subject compared to a patient, in this case, with early frontotemporal dementia. On the x-axis, we still have our speed. On the y-axis, we still have our power. And I've denoted here where the stimulus onset occurred. So one thing you might notice between the blue line and our orange line is that our early frontotemporal dementia patient has delayed speed. The peak in their waveform, it has shifted right on the y-axis. So they have a delayed speed for how fast they could process this information. Additionally, we see that they've shifted down on the power axis. So they have reduced power. They don't have very many neurons that are powering up together to process this information. Now, sometimes in a report, you might see a result that says indiscernible. This just means that the ERP was too slow or didn't have enough power to be detected. So in this example, we don't really see a strong ERP waveform like we do over here in the blue. So that means this ERP just didn't have enough power to be detected. Sometimes you'll see something with a really strong peak, but it has shifted way far right, and that means it's outside the window of our algorithm detection, because we're only going to look in a certain window of where the ERP should normally be occurring. And if somebody has a very, very delayed ERP, it might be missed by the algorithm and an indiscernible result will be provided. So indiscernible doesn't mean there wasn't enough data to interpret. It means that the ERP was too slow or not enough power. So an indiscernible result can actually be significant and important to pay attention to. Okay, so why do we care about event-related potentials when we're talking about TBI? As I previously mentioned, there are different components to the ERP waveform, and I was talking previously about the P300 component. So P300 is associated with attention, working memory, and executive function. And there are kind of two different aspects of it. P300A relates to attention, and P300B relates to information processing. Now, both of these things can be affected for somebody with a traumatic brain injury. And indeed, when we consider our speed of processing information, we can look at differences between a control group and a traumatic brain injury group in blue. And we see that our traumatic brain injury group has delayed latency, meaning they have slow brain processing speed. So we're going to keep out for our P300 component that has slow processing speed. We can also look at power. Remember, that's the y-axis. Power reflects neural recruitment. And when we look at our control versus TBI groups, we can see that power, also called amplitude, is significantly reduced for both the P300A and the P300B components. Now, in a graphical form, rather than a bar chart or a bar graph, we have time on the x-axis and amplitude or power on the y-axis. And this is just an example for P300B. We see our control group has a really high power, right? So a lot of their neurons are powering up to process that information. That is a very good, healthy ERP waveform. Our asymptomatic group has a bit of a reduced power, significantly different from our controls, and our symptomatic group has an even further reduced power. So it's showing, this graph is showing that our P300B power is important to look at for both asymptomatic and symptomatic concussed athletes, and that both of those groups differ from controls. So when we look at ERPs and our report, we're going to keep an eye out for delayed speed and or reduced power. Sometimes a concussed patient will have both, sometimes they'll only have one or the other, but chances are this biomarker is going to show up for somebody that has a traumatic brain injury. All right, finally, we have gotten to our resting state EEG. We know that EEG measures the electrical activity of the brain. Just for a quick orientation on this head, because we're going to look at head maps later, all of these circles denote the location of an electrode. We use the International 1020 system, so the locations of the electrodes are consistent. If you go and read clinical published research and they talk about CZ, that means it's this middle electrode located centrally along the midline. The naming convention is even numbers on the left, odd numbers on the left, even numbers on the right, and Z is down the midline. And then F, T, O, P, C refer to different regions of the brain. Okay, so when we look at head maps, there are two factors we're really interested in. The first is frequency, the speed of brain waves, and the second is power, which is the amount of activity within each frequency. So what frequency do you have, and how much of that frequency do you have? All right, so starting off with frequency, we know that brain waves occur in different rhythms, and that's created by different kinds of neural communication. Frequency just means the number of cycles per second. We measure that in hertz, and it reflects our brain's electrical activity. So these are some samples of different types of frequencies. They range from really slow to really fast. And we have different frequency bands to kind of group them together rather than being on a continuous spectrum. So first up, we have delta, which is our really slow waves. And delta waves correlate with really slow behaviors like deep sleep. Next, we have theta, which are a little bit faster. And these still correlate with kind of slower behaviors, feeling really drowsy. Next, we have alpha waves. And these alpha waves are our brain's normal resting state. We're producing mostly alpha most of the time. It's kind of our brain's pacemaker wave, just sitting, resting, relaxing. And finally, our fastest waves are called beta, and these are our brain produces mostly when we are really actively thinking about something or actively engaged in something. So we have this spectrum of slow waves to fast waves, and our waves correlate with slow behaviors and fast behaviors, things like deep sleep, all the way to concentrating really hard on a test. Okay, so we also care about EEG power, which is the amount of electrical voltage present within each frequency. And this gives us insight into how many neurons are working together to process information. And I'll note that all frequencies are generated in the brain at all times, but it's the amount of each frequency being produced that changes depending on what the person is doing. So remember when I said delta waves correlate with deep sleep? Well, right now, as I'm giving this presentation, I'm still producing some amount of delta waves. I'm just not producing that much. But when I'm asleep in the middle of the night, I'm producing a lot of delta waves. So what we do is assess resting state EEG for your patient, and then we compare it to a normal database to see how far off they are from normal brain function. And we measure this how far away they are from normal using z-scores, which represent standard deviations away from the norm. And we color code our z-scores using color of the rainbow. So blue colors mean they're far away from normal because they have low power. They don't have enough neural recruitment. Red colors mean high power. They have too much neural recruitment. So when we interpret our head maps, it's going to look like this, which has a lot of information. But if we ask ourselves 3 simple questions, we can get to the root of what's going on here. So first up is what frequency? We're looking at slow frequencies or fast frequencies. Remember that our kind of 2 to 10 hertz are slow frequencies. And we have this little graph down here that is produced in all of our newer reports. So it's kind of a cheat sheet. Our slow frequencies range from 2 to 10, and then our fast frequencies range from 10 to 30. So it's not a split down the middle. Our slow frequencies are here, and our fast frequencies are here. Now we also care about what power. Are we producing too much of this frequency or too little of this frequency? Remember, our power is using the rainbow. So blue is low power, red is high power. Now, remember, it's comparing the patient's brain to a normative database, so ideally we would like to see green in all of our frequencies. That means our patient is right on the money compared to our normative database. And finally, we care about what brain region. Now, this brain region can give us insight into different symptoms experienced. If somebody has too high power in the frontal lobe, maybe that means they have trouble with affect and mood control. And in the case of TBI, oftentimes the location will give us insight into where the injury occurred. So I'll note that this is not a structural assessment. It doesn't mean that there's a physical lesion there in the brain. It just means that there's dysfunction there, but that perhaps that's where the initial coup, counter coup occurred for when the concussion occurred. Okay, so resting state EEG and TBI. Why do we care about looking at EEG when we're assessing TBI? This is a great quote from Thatcher, who's a big pioneer in EEG and TBI research. And they say that QEEG is a reliable, objective, clinically sensitive, and inexpensive method to evaluate the effects of rapid acceleration, deceleration injuries to the brain. So basically, QEEG is very valuable when you're assessing concussion or TBI. Now, this is a sample figure from a study that was looking at patients with traumatic brain injury compared to a control group. And we have graphed here on the x-axis frequency, ranging from 0 to 30. So our slow waves are over here, our fast waves are over here. And on the y-axis, we have power, how much of each frequency is present. Now, our patients are in the black line. We see that they have more of the slow waves, and then they have kind of less of these medium waves, and then about the same fast waves. So they also produced a bar graph for us and looked at differences between our patient group and our control group, and we saw that there was a significant difference for delta and alpha waves, such that our patients had, oh, interesting, their key is off for this, but their patients had more delta waves being produced and too little alpha waves being produced. So in a head map, we would read this as high power for delta and alpha, or delta and theta, and low power for alpha. So there are a lot of different clinical studies. I referenced a few here, but there's a lot if you just do some quick Googling. And studies actually report altered brainwave production for delta, theta, alpha, and beta, all of our categories we're interested in, that can be related to TBI. So this is a sample figure from a great review, and it actually shows that some studies found decreased power for these different frequency bands. Some studies showed increased power for these different frequency bands. So there are kind of different results going on, and really what should we be paying attention to? Are these reliable? And really the difference between these EEG recording conditions could be giving us these different results. There's, of course, differences in injury type, severity, and onset, and comorbid conditions that all affect EEG and could be affecting these results, which is why we kind of are getting this inconsistent message between low power, high power, and what frequency band. So I'm going to note here that spectral analysis by itself, so basically looking at head maps, is not a sufficient detection tool on its own. It's really important to integrate these results with other electrophysiology metrics and look at the picture as a whole. None of these biomarkers are specific to TBI, but they're very sensitive to TBI. So we need to look at everything as one big picture. It's not just going to be one biomarker at a time. That's why we're reviewing 3 different biomarkers together and kind of trying to piece together a puzzle. And I'll point out, this is the Great Review article. If you want to do some further reading, they do a really great job of summarizing EEG and TBI, and kind of to date, it was published in 2015, so it's still pretty current. All right, so all of that being considered, what do you look for on a head map when you're trying to identify somebody with TBI? I'll first note out, ideally, we'd see all green, meaning our patient doesn't differ from normal. But most of the time, that's not the case. Their patients are coming to see you for a reason. Chances are something is going to be a little bit off in the way their brain functions. So with regard to TBI, first we're going to look at slow frequencies. And we want to see either low power or high power with a focal point. So this is an example of high power in slow frequencies with a focal point. See how it's pretty concentrated to this one area, and it does get a little bit larger here. If I showed you the extended image, this red would resolve after 10 hertz. So it's very focal in where the abnormal function is. Or we can see low power, which is blue, in our slow frequencies, again with a very focal point. See how it's only in this specific area. It's not diffuse and covering the whole brain. Now, additionally, we can look in our fast frequencies, and in our fast frequencies, we're really looking for neuroinflammation. And typically we see neuroinflammation after things like a motor vehicle accident, and it kind of represents that the brain is inflamed, having a cytokine reaction to the injury that occurred. So neuroinflammation looks like high power in the beta band, again with a focal point. So see how the red, the high power, is confined to one region. So that's neuroinflammation, but it's focal, and that can be linked to things like a motor vehicle accident or a really severe concussion from a sports injury. Now, it's different from neuroinflammation that we sometimes see due to autoimmune responses or infections, things like that. And that would be red everywhere in the brain, not just in this focal point. So the key here is you're looking for brain function that is confined to a certain region. And remember, that kind of gives us insight into where that injury occurred. All right, so a summary of our TBI biomarkers we're interested in. First, heart rate variability, time and frequency domains. We're looking for reduced HRV and/or sympathetic dominance. Event-related potentials, we're interested in the P300 waveform, looking for delayed power and/or delayed speed and/or reduced power. And finally, resting state head maps. We're looking for high power or low power in our slow frequencies with a focal point. And we're looking for neuroinflammation, which is high power in fast frequencies with a focal point. All right, so what do these things look like for our athletes and for our patients? Let's keep in mind, athletes, chances are you know that they had a head injury, and the question is, when can they return to play? For our patients, it's a bit more of a mystery. The question is, what is causing their symptoms? Could it be related to a traumatic brain injury? So starting out first with our athlete cases, this is an example of a 22-year-old football linebacker. We know he had a concussion 10 days prior, and he's currently asymptomatic, so he's feeling great. He wants to get back to play. And he's coming to me asking, am I ready to go back to the field? So I look at all of these electrophysiology assessments. First, I'm going to look at heart rate variability. Well, I see he has a reduced SCNN, he's got a reduced total power, and he has sympathetic dominance. So that's one of our biomarkers. I'm also going to look at our ERPs. It looks like he's pretty good on ERP speed, but his power is a little bit reduced. 12 and 11 is kind of on the low side. Really, we'd like to see high teens or low 20s or even above. So I'm a little bit concerned with the low power for his P300. And when I look at his head maps, I'm seeing low power, slow frequencies with a focal point. That's one of our biomarkers too. So overall, my conclusion would be, nope, this patient is not ready to return to play. They might be asymptomatic, but their brain is still injured and still needs to recover. So let's move on, look at another case study. This is a 28-year-old MMA fighter who was sparring 3 and 5 days before the assessment. He's feeling great. He has no symptoms, no complaints. So when I look at his HRV, he's got a great SCNN and a great total power. He's in very good shape, but he has sympathetic over-arousal. So I'm a little concerned with his sympathetic dominance. When I look at his ERPs, I see that his P300A and B are delayed. So I'm concerned with that. And when I look at his head maps, I see low power, slow frequencies with a focal point. So my conclusion would be, nope, you're not ready to get back in the ring yet. You need to have some rest and recovery. And finally, let's look at another MMA fighter that had a big fight 2 weeks prior to our assessment. First, we look at our heart rate variability. We've got good SCNN and total power, but we have sympathetic over-arousal. And actually, a bit of a low SCNN, considering this is an MMA fighter. He should have a very high SCNN. We're right on the border of our reference range. Now we look at our ERPs, it looks like there's not even a P3B to be detected at all. So I'm very concerned with the lack of a P3B. And when I look at our head maps, I see high power in our slow frequencies with a focal point, and I see a lot of neuroinflammation. So I'm really concerned with that. He's definitely not ready to return to the ring. He had a big fight, he took some major hits, and his brain is still recovering. So when it comes to athletes, preseason testing can be really helpful, and getting a baseline assessment of functional physiology can help track brain health through the season. So as an example, let's look at a football player that had low impact during the season. These are his preseason results. We see a little bit of low power, but everything's pretty diffuse, nothing to be too concerned about here. Good SCNN, total power, and a P3B. Postseason, not much has changed. Our SCNN, total power, and P3B are almost identical, and we still have that kind of slightly diffuse low power. We didn't do any active brain training with him, so we wouldn't expect the low power to resolve. He's good, nothing to be concerned about. In comparison, let's look at somebody with high impact. So this is somebody that played a lot during the season. They're in great shape before the season, but after the season, we see the reduced SCNN, a reduced total power, a reduced P3B power, and we see they have high power that's confined to focal regions in our slow frequencies. So this is somebody that played a lot, took a lot of hits, their brain is injured and functionally injured, and they shouldn't return to play right now. They need to rest and let their brain recover. Now, as an example of using these biomarkers to track somebody throughout a season, let's revisit our football linebacker who was asymptomatic, but we discovered that really his brain is still injured. He shouldn't be returning to play. Now, if we had assessed him at baseline, and actually we did, we saw that he was in pretty good shape with his head maps and his ERPs, and then he had a concussion a couple days later, and then we assessed him and we decided, no, you might not be having symptoms, but your brain is still recovering. Now, we gave him some rest and recovery, and then a couple months later, we saw that his brain bounced back. This is now true recovery. We can see that his low power has resolved. It's no longer focal here. It's just kind of this very slightly low power, more diffuse, nothing to be concerned about there. And our ERP has returned nearly identical to what it was before in comparison to when it really dropped in power here. All right, so let's switch gears, talk about a few patients before we wrap up. This is a 51-year-old male who's concerned with word finding, poor focus, and erratic mood. First thing I'm going to look at is my heart rate variability. He's got low SCNN, total power, and he has sympathetic dominance. That's one of our biomarkers. I look at his ERPs, and it looks like he has a delayed P3A and a really poor P3B that couldn't even be detected. And when I look at his head maps, I'm seeing some high power in our fast frequencies. That's really focal. Remember, that's one of our biomarkers of neuroinflammation. So we have focal neuroinflammation. Altogether, these things make me think traumatic brain injury. So we do some more questions. We figured out he was in a car accident 1 year ago. His brain hasn't recovered well. It's this activity that's making him experience all of these symptoms. And then we can train the brain to recover from this injury. Right, another patient case study, 54-year-old male. He has headaches, sleep problems, memory problems, anxiety. I look at his HRV results. I see low SCNN, low total power, and sympathetic dominance. I'm looking at his ERP, and I see a slow P300B. And then when I look at his head maps, I'm seeing low power. That's pretty focal in our slow waves. And I'm seeing our focal neuroinflammation in our fast waves with this red power here. So the conclusion here is, once again, it's probably a traumatic brain injury. Do some digging, figure out they had a car crash, and all of their symptoms are related to the brain not having recovered functionally from that car accident. And let's take a look here at a 30-year-old male who has fogginess, fatigue, and headaches, which he's really concerned about given his age. He's a young guy. I look at his HRV. He has a great SCNN and total power, so this person is really in shape. They're really fit, but they actually have parasympathetic dominance. Now, this isn't what we've seen typically in our TBI patients, but this parasympathetic dominance means they're stuck in rest and digest. That's probably why he's experiencing a lot of fatigue. When I look at his ERPs, I see that he has a poor P3B. He's delayed out here, so I'm concerned about the P3B. When I look at his head maps, I see that there's actually a bit of high power here in our slow frequencies, and that's pretty focal. It's kind of confined to this left part. And when I look here in our fast frequencies, again, I'm seeing some high power, which looks like a little bit of focal neuroinflammation. So this wasn't a huge car accident. That would be something really obvious. But when we questioned him more, we figured out he had a head collision with his Great Dane dog 8 months ago, and that's what's causing this. He did have a little bit of functional brain injury. His brain hasn't recovered, so we're going to train the brain back to health, and he'll overcome these symptoms. Finally, moving on to a 69-year-old male. He's complaining of mood problems and anxiety. I look at his HRV. He's got low SCNN and sympathetic dominance. I look at his ERPs. He's got poor P3A and P3B. And I look at his head maps. And here I'm seeing something a little bit different than I did before. I still have low power, but it's pretty diffuse throughout the entire brain, and it continues from our slow frequencies all the way through our fast frequencies. So this to me doesn't seem to be TBI, right? It's not a focal injury. It's very diffuse throughout the brain. So this doesn't match our biomarker for TBI. Our conclusion is it's likely depression. Now, if you are confused on why it might be depression, refer to our Lunch and Learn on depression. Shoot me an email, I can give you the link. And one more case study before we wrap up. This is a 51-year-old male who has forgetfulness. Their HRV, they have low SCNN and sympathetic dominance. That's one of our biomarkers. We look at our P300. Their P3A isn't discernible. And although this P3B was detected by the algorithm as healthy, it's actually not discernible at all. This isn't indicative of a P300 waveform, so I'm worried about their P300A and B. And when I look at their head maps, I'm seeing something different again. Looks like they have high power in their slow frequencies, but it's pretty diffuse everywhere. And then they have low power in these fast frequencies, which is also pretty diffuse. And I'll note they also have a really low peak alpha frequency. So overall, these head maps don't match our biomarkers for TBI. And my conclusion is that this could be dementia. Now, if you're confused on our biomarkers for dementia, you can also refer to our Lunch and Learn on memory loss. Now, wrapping up, medically guided bio and neurofeedback can be really helpful as an intervention for brain injuries like TBI and blast concussion. And devices like EVOX can provide easy-to-use in-office biofeedback designed specifically for your individualized patient. And it helps physicians target training based on ECG and EEG biomarkers. So all of this assessment component can plug into your treatment component. It can train to a reduced heart rate variability back up, because we want high heart rate variability. And it can also train suboptimal brain regions that might be associated with clinical symptoms. So a quick knowledge check, and then you're free to go. First off, patients with TBI often have low or high SCNN and total power. Remember, patients with TBI have low SCNN and total power, when ideally we would like to see high. HRV high frequency correlates to what kind of dominance, and very low frequency correlates to what kind of dominance. Remember, our high frequency is parasympathetic, our very low frequency is sympathetic. Patients with TBI often have which kind of ANS dominance, parasympathetic or sympathetic. Typically, we see them having sympathetic dominance. ERPs are a metric of brain processing speed. Patients with TBI often have delayed what and or reduced what for the P300 waveform. These are our two components for ERPs. We're looking for delayed speed and reduced power. Now, which of these head maps shows a biomarker of TBI? We have a snapshot of our slow frequencies, and we see low power in both. Conversely, we could also see high power, and that would still be a biomarker of TBI. So how to tell which one could be linked to TBI and which one probably isn't? It's all about the focal region, right? So here we see focal low power. Here we see diffuse low power. So we're going to conclude that it's this lower set that has the biomarker of TBI. But remember, we're always assessing things as a whole before drawing a conclusion. We're not just going to conclude this is TBI by looking at this picture alone. We care about all the other biomarkers too. And finally, neuroinflammation associated with TBI can be recognized by low power in the beta frequency band in focal regions. Okay, well, thank you so much for joining us today. I really appreciate you spending your lunch hour with us. Feel free to shoot me over any questions. If you want to expand upon any of these talking points, I'm happy to do so. And thank you again.